Okay, I think we've got a good number of people have joined us now, and it's just ticked over after 1 o'clock here in Melbourne, so we might make a start. Just wanted to welcome you all. I'm Angela Jones from the Monash Partners team, and I'm joined today by Darshini Aiton, one of our Consumer and Community Involvement Fellows, and Victoria Kutsubis, and three fabulous speakers this afternoon that I'm going to introduce in just a moment. Madeleine Gardam, Steiner and Ben Horgan. And the focus of our monthly CCI seminar this month is really hearing from the perspective of consumers who've been involved in this type of work around what works and doesn't work in bringing consumer and community involvement into research and healthcare improvement activities. I'd like to begin by acknowledging the traditional custodians of the land on which I'm standing and we're all meeting today across Australia. And in the spirit of reconciliation, I pay my respects to elders past, present and emerging. I extend my respects to any Aboriginal and Torres Strait Islander joining our seminar. Wherever you are, I acknowledge and pay respects to our First People. Just a little bit of an overview of our seminar today. What we seek to do at Monash Partners is connect researchers, healthcare professionals, health services managers and consumers to innovate for better health. We really are focused on learning from each other, and we think this provides a terrific platform to do this in the context of consumer and community involvement. Today's seminar is being audio and video recorded, and we'll also save the chat. After the seminar, we'll send you a summary of the key points, and we'll also make the seminar available on the website. Please dive into the chat during the seminar and share with us questions and insights that you may have. We'll be monitoring the chat throughout the session today. Just to remind you, Monash Partners has a comprehensive suite of online training and resources which are all free and self-paced, and they can be accessed via our website, and the address is there. We also offer advice and support to groups across Monash Partners wanting to strengthen their proposals by including consumers and community members. So please reach out to us if we can support you in any way. We're delighted to across the Monash Partners network. And we also have on our website a series of tip sheets that we developed in the context of COVID to guide healthcare professionals and researchers around how to engage with consumers using various online platforms. And of course, we also have this regular event as well. Just to remind you of a couple of our future seminars, we're going to take a break in July while the school holidays in progress, but our August seminar will focus on consumer and community involvement and ethics, talk through the principles of involving consumers in an ethical way, and also talk about the process of developing an ethics submission and involving consumers in that. And then in September, Helena Teed, who's the Executive Director of Monash Partners and has a lot of experience in writing grants and incorporating consumer and community involvement into those, will give some tips and hints around how to do that in the context of developing a grant submission. So without further ado, it's my great pleasure now to introduce our first presenter this afternoon. Maddy Gardam has over 10 years of relationship and program management experience across a wide range of sectors, including education, public health, career strategy and talent management. And she's got great experience in leading teams in long-term complex projects. Maddy holds a Bachelor of Arts majoring in psychology and criminology, a graduate diploma in psychology, and she recently completed a graduate certificate in career development. She's very strongly and passionately connected to consumer and community involvement. Maddy herself has type 1 diabetes that she developed some 8 years ago, and she's also a secondary carer to her dad, who is living with younger onset dementia, which was diagnosed in the same year as your diabetes, Maddy. So certainly you had a lot happening in your life during that year. Maddie's also worked for one of the Monash Partners organisation, Monash University, which is our lead academic partner, on a very, very large clinical trial called Asprey, which some of you may be familiar with. And she worked very closely during that trial with the elderly and also on the dementia registry and cystic fibrosis. Maddie, welcome, and thank you for making the time to join us today. And it's my great pleasure to hand over to you.
Thanks, Angela, and thank you for the warm welcome and for the opportunity to speak in this forum today. I'm really pleased to be here. I'm pleased to see that there's such interest in learning about consumer and community involvement. So Angela has asked us to, I suppose, speak to a couple of questions and share some perspectives. So I'll just facilitate myself. What are my key learnings from consumer and community involvement work so far? I think, my observations, I suppose, until I was diagnosed with a health condition myself, I probably didn't really think much about any of this as a well person in the community. But certainly over the last 8 years that both myself and my family have been on this trajectory in healthcare with some really varied experiences, it's been great to see that I think there's been really meaningful progress in this space, which was much needed and much called for. I think, another sort of learning or observation is I think clinicians and researchers have recognised that they don't necessarily have expertise in how to work with consumers and the community, and I suppose the broad range of diversity. Their expertise is in other areas of healthcare and research, but that recognition that this is an area for development has been, really pleasing to see as well. I certainly, in my own experience with consumer and community involvement, have seen the progression in, I suppose, helping develop the skills of consumers as well. So almost what I'd call the professionalism or professionalisation of being a consumer. So rather than just being invited kind of informally to attend something so that someone can put our name on a grant or on a paper, I think it's great to see that we're being invited in more meaningful ways to participate and be involved, but also that we're being provided with resources and training and support around that. And I really credit Monash Partners on the work that they've done in this space. Having participated in some of their consumer training, I found it to be really comprehensive and well evidenced. And it's certainly that type of training was helpful for me to understand my responsibilities as a consumer, to encourage me to be a professional consumer, if you like, and bring that level of discipline to my involvement. I think the other key learning, both from, Angela mentioned some of the work that I did in my brief sojourn into public health with Monash. Consumers really want to be involved, and that's certainly my own experience. It's certainly my family's experience and the experience of that I've observed with, with others that I've worked with across various health research projects, but they want to be involved only in a meaningful and real way. I think my other key learning from this type of work is that consumer burnout is a real thing. It's something I've certainly experienced myself. I've certainly seen my parents experience it. It's very easy to get on a bit of a circuit when you are the sort of person who's happy to be involved in this, in consumer and community involvement. And I certainly have observed my parents really got on a bit of a roll there with dementia involvement for a while. And I think particularly in those early stages of diagnosis, while you are well and able to be involved, you can become the poster child for a cause quite easily. And whilst was a very meaningful and productive thing for my parents to be involved with and for our family to be involved with, it does also take its toll. So I think that's something that's really worth being mindful of, is almost sharing the load a little bit. And I think probably my other key learning or observation is that I think we do tend to hear some of the same perspectives. And I say that sitting here as an educated Caucasian middle-class female. So I do think that we still have challenges around accessibility for consumers to participate in these types of forums, for a number of reasons. And I'm sure we can dig into some of that later. Angela and the team also asked us to share our best or worst experience of consumer involvement engagement, and I thought I'd share one of each, and I'll start with worst because I like to end on a high. So my worst experience was I attended a roundtable type event. So it was consumers and clinicians and researchers who had all been invited to be in the same room and were asked to sort of listen to some presentations and then collaboratively work in small teams to rank and evaluate research proposals to decide what would get funding. And I was really excited about being invited as a consumer to participate in this group because I think, you know, having consumer voices in the type of research that's funded is really important, not just the research itself. So I ended up in a small group as the sole consumer with a group of clinicians and researchers, and a senior endocrinologist was a part of that group. And I introduced myself and actually noted that we both happened to know somebody in common. And so he asked why I was attending the event, and I explained that I have type 1 diabetes. And his next question was, well, what's your HbA1c? And for those who are not familiar with diabetes in the room, it's essentially a key performance indicator of my blood glucose control. And so that question is a little bit like asking somebody how much they weigh. It can be quite emotionally loaded, it can be rude, and it's a little bit of a measure of how good, how compliant you are as a diabetic. And I think at the time I was, you know, I'm a fairly outspoken, confident person, and but even I was so shocked that I firstly actually answered the question, but then he proceeded to give me his thoughts and feedback on that as well. So I think it was just a disappointing experience because I felt that it reduced me to a number and really only recognised my kind of existence as a person with diabetes rather than, you know, diabetes being a part of who I am, but you know, Angela touched on my professional identity. I, you know, have a family as well. So there's lots more than my diabetes and my HbA1c. And there's a lot of, I think as a clinician, you know, I would have hoped you'd had awareness that, that the HbA1c, you know, is one measure of success. So, so that's a kind of, I suppose, my story of what not to do. In terms of some of the best experiences, and these have been more recent. So I was invited to a grant application discussion for a dementia grant, which involved a behavioural researcher, a qualitative researcher, and a geriatrician. And sometimes these invitations, when you get asked, you know, it's quite tokenistic because people want to be able to put your name on a grant and say that a consumer was involved, but it certainly wasn't my experience in this situation. You know, some of the things that made this different was that everybody on the call introduced themselves and explained their role. I really felt like I was being treated as an equal in the discussion. So I think sometimes in people's, you know, desire to make it simple and help explain, it can almost be dumbed down too far and then it comes off as being disrespectful, or sometimes people go the other way and it's so complex that you can't participate. And that's a really fine balance to strike, and I appreciate that that's difficult, but this particular group of individuals kind of, I suppose, took the time to understand me and where I was at and involve me in that discussion, inviting my ideas, listening, acknowledging them and incorporating them in the grant as well. So it's one thing to listen, it's another thing to actually take it on board. So I think they also really asked me how I'd like to contribute and what contributions I could make. And then they also kept me in the loop on progress. So I heard about the outcome of the application. I was kept in the loop. Another positive that I'd like to share actually is I've had a bit of experience being involved in clinical trials for diabetes as a participant. And you know, some of the trials that you get asked to do can be quite invasive and a bit uncomfortable, and that's okay. Like, you know, that's part of the process. So one trial I was involved in early on after my diagnosis involved riding an exercise bike so that they could get a VO2 max read on you as one of their measures. And the two cardiologists who were running this particular intervention were particularly keen cyclists. So they were really proud of the setup that they'd organised in the lab. They had really great gear that was kind of top of the range. But the bike seat was crippling. It was the most uncomfortable seat to sit on. And so I gave them some feedback about the seat. And so when I returned for my follow-up appointment, they were very proud to unveil a gel cushion cover for this seat, which made it much more comfortable. I'm sure it greatly reduced the glamour and tech spec of this seat. But again, they listened, they took action, and it actually made a difference to my experience in being involved in their trial. And they didn't just trivialise it as discomfort or a minimal problem. So they're probably my two best experiences. In terms of what would better look like, again, I just want to acknowledge that there really has been a shift in the last 8 years. So I'm confident that we're on a pathway forward. And again, I think the work that Monash Partners is doing in the resources, the practical guidance, the research that's being done in this space is really excellent. I can see that clinicians and researchers are taking responsibility for doing this work better. And a lot of the time it's really simple things that we have to do, but it takes time and resources and sometimes money. And I know that that is in short supply in this space. But I suppose my sort of five things that could be done better. Accessibility and inclusion of perspectives across the whole community. And I recognise that that can be challenging with diverse languages, regional and rural areas, but I think we do have to find a way to include more diverse perspectives. I think sharing the load is something we need to do better. So making sure that we engage a broader pool of consumers so that it's not the same people being called on all the time. I think recognising burnout is really important, and probably considering the timing of your approach when you're asking a consumer to engage. So for some conditions, it may be that diagnosis is really the time that you do need to engage, but for other conditions, it can be that it's not. And of course, there's individual difference as well, and it can be hard for you to know, but ask if it's a good time for them to be involved, or would you like to come back and participate later, or would you like a break from the circuit for a while? I think the other thing we can do better is to continue to develop the skills of researchers and clinicians from junior level through to senior experienced professors as well, dare I say. I think there's varied engagement, and I've seen people who've really come and implemented the advice that they've been given through training programs like what Monash Partners is doing, and then I've seen people who have attended and gotten access to consumers and not implemented that. So I think we can continue that skill development. And then lastly, I think we can do better at really enacting the advice of groups like Monash Partners around CCI, engaging in the training. I mean, I think it's a huge thing to put on a seminar every month on a different topic. So congratulations, guys, on doing that. I really encourage, and I'm probably preaching to the choir a little bit in the attendees here today, but to come and engage with this advice and guidance and the expertise that's available, and use that in your practice. So that's it from me. Thanks, Angela. I think I've just kept to time.
Maddie, thank you. I think you beautifully highlighted through your stories what's really important, the finer things to get right. That whole communication and engagement piece is so important, isn't it? Making sure that we communicate respectfully and appropriately, that we provide information that's understandable. Absolutely. So thank you so much for sharing with us your experience of being involved. And I think there's some really fabulous take-home points that we can perhaps pick up in the discussion. It's now my great pleasure to introduce Anna Steiner to you as our second speaker today. Anna is passionately and extensively engaged in advocacy, volunteering and fundraising, with a particular interest in blood cancer research. And she works with a number of organisations, including the Australian Centre for Blood Diseases, Peter MacCallum Centre, Walter Eliza Hall Institute of Medical Research, St Vincent's Centre for Applied Research, and the Nepean Clinical School Leukemia Foundation, and is also an executive administrator within an organisation called Women in Lymphoma, which is a global alliance for female clinicians, researchers and educators in the field of lymphoma. And it's particularly passionate about this, having lived with a condition called polycythemia vera since 2008, and polycythemia vera is a chronic and fairly rare and incurable type of blood cancer. She's a member of a committee of Myeloproliferative Neoplasm Alliance Australia, which obviously brings people together to progress better care of this particular condition. And thank you so much for taking time to join us today. It's great to have you here, and over to you now.
Thank you, Angela. Firstly, I'd like to thank Angela, Sarah, Dash, Victoria, and the whole Academic Health Science Centre team, and everyone else who's involved in putting on this webinar and the series. Thank you for including me today, and also for continuing to provide support and opportunities for all the consumers. I'm going to be reading today, but I'm open to questions and discussion as well, but I just keep on topic and not forget things, hopefully, if I read. So also I acknowledge the traditional custodians of the Gubbi Gubbi land on which I live and work, the Kabi Kabi and Jinnabara people, and I recognise the continuing connection to land, water and community. I pay my respects to elders past, present and emerging. The first question we've been asked to respond to is, why did you choose to be a consumer? And the short answer is, I think, for me at least, consumer advocacy actually chose me. Volunteering and fundraising have always been an integral part of my life. And after being diagnosed with a rare and incurable blood cancer almost 13 years ago, I chose to focus my time and energy on blood cancer advocacy. At the time of the diagnosis, I was living in Asia where there wasn't a relevant support group. That's because the NPNs are rarely diagnosed there in racially. So with the help of NPN Voice in the UK, I started my own very small support group of 3. Then when I would visit Australia, I would go to Leukemia Foundation conferences and support groups to gain more information, meet others living with the same or similar blood cancer. And that was the beginning of the advocacy and consumer and community involvement for me. Then I moved to Australia about 5 years ago and made a bigger commitment to volunteer, advocate and fundraise for blood cancer. And as Angela mentioned, I'm now involved with quite a few organisations, including Monash Partners, the Cancer Council Victoria, Tour de Cure Cycling Charity, Peter Mac, hi Anna, We High, ACBD, Leukemia Foundation, Snowdome Foundation, and on the committee of NPN Alliance Australia. My involvement with these organisations includes focus groups, collaborating with researchers, co-organising events, advocating research and news to support groups and more. It might sound like a lot, although it's all voluntary, which means, of course, I very happily, enthusiastically choose to do it all. Volunteering, advocacy and fundraising literally makes my blood pump. It gives me purpose, involvement in breakthrough research in my own blood cancer and others, and a way to counterbalance any negativity of living each day with an incurable blood cancer. If the feel-good factor of engaging for myself and many others could somehow be measured, it'd be many, many times higher than any negativity I feel with the distressing symptoms of PV. The reality of living with an incurable cancer, the burden of a chronic disease for myself and others, as a daughter, sister, mother and friend. The first consumer role I was involved in was at We High, where I continue to be involved, when I heard of a research project in the rare blood cancer that I'm living with. Research into PV seems to be as rare as the disease itself, so I got a little excited, contacted the lead researcher, met with her to hear more about the project, and met the whole research team. I then initiated a grant application with a private funder for that project. Have since assisted that team with further grant applications by reviewing and editing the documents as recently as a few weeks ago. That connection led me to join a community representative group at We High, the Consumer Buddies, which includes training, webinars, lab visits, advocating and sharing milestones and results. As much as I want to participate in. This year, I'm also involved in blood cancer research projects, Peter Mac, ACBD, and others in Sydney and Brisbane. And I'm an associate investigator on some of the projects. All of these projects have timeline funding. So what does consumer and community involvement involve? I think the first answer is really many, many things, though also as a consumer, whatever you choose to be involved in, when and how it suits you, your family, your health, your work and other commitments. The benefits of community representatives being engaged are boundless. We as patients and carers have much to give directly and indirectly to organisations, researchers, clinicians and others in our lived experience as patients or carers, relating to diagnosis, treatment, cost, access, equity, trials, much more. It can be in person, virtual, in a focus group, a written submission, anonymous. There's no strict prescribed pathway for all projects. Some projects are completed in one Zoom meeting, others engage the team for weeks or months, regularly or sporadically. Another question we've been asked for this webinar is about examples of where consumer involvement worked well and also perhaps didn't work so well. Overall, I have really only encountered very positive experiences in this space, though the process really depends on the level of engagement and interest of the researchers and their teams. Consumer participation, particularly with research grant applications, is a relatively new concept for many. And there's researchers on both ends of the spectrum, very experienced or early career, who are perhaps a little uncertain of the role and importance of the consumer's participation. Perhaps that would be the only negative, is I've been asked sometimes, been sent the very last page of a grant application, somewhere to sign and return within 15 minutes, please. So that's changing. And obviously that's not the best way to do it. So some might feel that a name and signature at the end of the documents will suffice, although for Cancer Australia, NHMRC and others, this isn't enough. And they've needed to, the researchers may need to adjust their thinking and include consumers more. Thankfully, organisations such as Monash Partners, ACVD, WeHi, Peter Mac, etc., have very capable teams and leaders facilitating the consumer partnerships with training and support, which makes these partnerships very positive. So I think that training, support, resources, teamwork and communication are the keys to positive and productive consumer and community involvement partnerships. When the researchers are aware of the consumer's role and the consumers are briefed on the expectations of their participation and meetings are regular, open, informative, then the engagement can be very positive. It's the delivery, the message, the impact on patients and carers, the human aspect that consumers inform, consult and share with professionals. We are the experts in our own health, and more that's becoming greatly valued and listened to. So it is invaluable to organisations such as Monash Partners to have this input. Inclusion of more diverse groups and individuals, as Maddie said, as consumers would make community participation even better. To include regional, rural, diverse cultural views and experiences as much as possible and relevant would be excellent. Contributing in this space can be very empowering for a consumer. Personally, it brings me a lot of hope, learning and purpose. Each of us can make a real difference and positive impact on preventing, for instance, cancer and other chronic illness, empowering people and even saving lives. We are the experts in our own lived experience as patients and carers. And now more than ever, as our country continues to navigate this pandemic and as decision and policy makers reassess and realign healthcare delivery and set priorities. Patients and carers play a valued and important role in the journey of research and the development of new strategies and policies. Organisations, administrators, clinicians and researchers need to and want to hear these voices of patients and carers and their experiences. The opinions of community representatives are leading to positive and important changes in healthcare policy, outcomes and funding across our country. Thank you.
Thank you so much, Anna, for sharing with us the depth of your experience. Is quite amazing. Also, the what it brings and the level of personal satisfaction that you have around being involved in these activities. And also, I think you highlighted beautifully how we have to build capacity of researchers and clinicians to do this really well, and then also support consumers from a wide range of backgrounds and clinical conditions to actually do this as well. And you rightly point out that while it's very positive and inspiring work, it's also very taxing, and we need to be incredibly mindful of that. So thank you for sharing your experience so generously today. It's my great pleasure now to introduce Ben Horgan. Ben has a leadership role in consumer and community involvement in Western Australia, supporting the activity of the Western Australian Health Translation Network, which is a similar entity to Monash Partners, bringing together clinicians, researchers and consumers across the whole state of Western Australia, which is no mean feat given the geographical scale of Western Australia. It's been a great pleasure for us at the Monash Partners team level to work closely with Ben as we've built our platform. He's very generously shared the learnings from a lot of work that's been done in Western Australia. Ben shares his time between Curtin University and the Western Australian Health Department Research and Innovation Office, and brings nearly 20 years of advocacy experience to his current role. He's worked at organisations such as Arthritis Australia as a consumer advocate, and worked for several years in primary healthcare organisations supporting patient-driven, evidence-based and multidisciplinary care. Ben has been a consumer representative in state and national committees, and was the first patient to be appointed a national coordinator by the World Health Organization initiative, the Bone and Joint Decade, from 2000 to 2010. As a patient research partner, he's worked extensively in local, national and international research projects. Ben's current role enables him to utilise all of this experience and evidence-based best practice models to improve collaboration between researchers, health consumers and the community. Ben, thank you for taking time to join us today. It's our great pleasure to have you, and over to you.
Thank you, Angela. It is my pleasure to be here today. As you've heard, my role within the WA Health Translation Network allows me to work with researchers and consumers, or people with a lived experience, to be able to increase collaboration and hopefully develop better research projects to generate outcomes that improve people's lives. So in that role, I get to put my own experience behind me, but today I get to tell you a little bit about how it all started for me and how my journey as a consumer has got me to where I am today. So I was diagnosed back in 1973 with juvenile rheumatoid arthritis, and I was very lucky to be born into a family of incredibly determined people. My mum had no idea at the time that children could get arthritis, so she was very determined to make sure she was as up to date with the knowledge and the evidence around this disease as possible, not only to help me, but to help potentially other people as well, because she didn't want people to be in the position that she was in, totally naive to the situation. So Mum worked, back in the old days when there was no internet. Mum visited all sorts of libraries and arthritis foundations and other institutes that were interested in developing more knowledge around this issue. And she built up quite a big network of people in similar situations. So back in the day, her Teledex was full of parents who had kids in a similar situation. By the time I was about 10, Mum decided to do a bit of research herself. Now, she hadn't gone to university. She certainly wasn't doing a PhD. As I said, she was just an interested mum who wanted to try and find out as much as she could and share that information with as many people as she could. So she developed her own survey and sent it out at the time to about 100, 150 families. And obviously back then it was just in those big A4 manila envelopes, and not surprisingly, I suppose, but at the time Mum was amazed. She ended up getting about an 80% response rate within, the first month of sending it out, and some really fascinating information came back. But I think the fact that she got such a high response rate motivated her to continue down this path and find out more. Because as we all know in research, if you do a project well and you ask the right questions, you actually end up with more questions than you have answers. So a couple of years after this initial survey that Mum sent out, she ended up with about 500 families that she was aware of, because, you know, these people who had responded to Mum put other people in touch with Mum, and the network just grew. So Mum decided that she needed to be a little bit more comprehensive and not just send a survey of a couple of pages out to the parents, but she actually developed a survey for the children themselves, for the rheumatologists, for the physios, for the social workers, for the siblings of the child, even for the teachers who were working with these children in schools. And it was, once again, amazing. The response rate was around 80%, not only from the parents and the families, but also from all of the clinicians, allied health professionals, teachers. Everybody gave their time to Mum and this project. Our house ended up looking like a research institute. We had those big cardboard boxes full to the brim. Our dining room turned into the War Office, and Mum had all of this information available to her, and coincidentally, Dad was actually in publishing at the time, so Mum was able to write a book with all of this information, and it was really the first of its kind to be published around the world. It was published in 1983. It was called Arthritis in Children, A Practical Guide. And the first of its kind because it was written from a layperson's point of view, who had done all of this research. And each chapter was relating to a particular specialty that engaged with families with a child with arthritis. And she had co-authors from all over Australia help her to write those chapters. This is how I got involved in research and how I was fascinated with research, because I could see the difference that it could make from just asking questions and being involved as somebody with a lived experience of the disease rather than just an interested researcher or clinician. When I got a little bit older, I was contacted by an organisation called OMERACT. OMERACT stands for Outcome Measures in Rheumatoid Arthritis Clinical Trials. It's a global organisation that looks at designing the tools that are used to research arthritis. Rheumatoid arthritis at the beginning, but they do all sorts of inflammatory arthritis topics these days. Even though I'd had a lot of experience from Mum being involved in research itself, I was quite nervous. I was invited to America to attend a conference. It was the first time that consumers were invited as full members of OMERACT. There was about a dozen of us from all around the world. And I wasn't really sure what my experience was going to be able to contribute to. There was the world's leading experts in inflammatory arthritis attending this conference. Here was me, just a bloke from Australia who'd lived with it for a while, but I certainly didn't know the science and was a little nervous, as I said. So we arrived at the conference, and the first morning of day one, we were invited into a discussion which was looking to define flare in rheumatoid arthritis. And we were separated from the rest of the attendees, so all the researchers and clinicians were sitting in the big ballroom area, and the consumers were in a smaller room off to the side, which was a bit of a red flag for me at the time, because I felt like we should all be together, and why we were being separated so early, I wasn't sure. Anyway, it became clear to me. The way they asked us to contribute to this discussion around defining flare is they gave us some de-identified core sets. They were literally just cards with 6 scores on them. There was a score for quality of life, there was a patient global, a physician global, there was some blood results, and there was number of inflamed joints. And that's all we had. We didn't know where this person was from, how old they were, how long they'd had the disease. We just had these scores, and we needed to make 2 piles. They wanted us to make a pile of people who we felt were in flare, and they wanted us to make the other pile of the people that we felt probably weren't in flare. It was really difficult to do, and we all had our own experiences and what we thought flare was to us. So we needed to come up with a strategy that enabled us to undertake this exercise. So we came up with a theory as to what would work, and sure enough, we made 2 piles. At the same time, the clinicians and researchers in the other room were doing exactly the same project, with exactly the same cards. And then, so they finished, we all came together, the research team took away the results of our little exercise, and about 10 minutes later, they came back to present to the whole group. And they looked a little bit confused and maybe somewhat disappointed. And they thanked us all for the time. They felt like maybe it didn't give them the answers they were looking for, because ultimately what happened was our pile of people that we felt were in flare, the patient's point of view, was almost totally different to what the researchers and the clinicians thought. So the research team felt like maybe this hadn't worked, as I said, the way they wanted. It generated discussion, as usually these things do, and it became evident that the way we went about deciding who was in flare and who wasn't was basically different from the two groups. So the consumers, we prioritised quality of life over all the others. So if the quality of life score was good, then we felt that these patients could not be in flare. Being, having a lived experience, we knew that this is a very unpredictable and fickle disease, and you can be up and down like a yo-yo even in one day. But generally, if you felt like, if your quality of life was okay, we couldn't put you in the flare pile. On the other hand, the clinicians, they were prioritising the blood results and the number of inflamed joints. They weren't really taking too much notice of the quality of life. They certainly weren't looking at the patient global results. What that said to me, and what I've learned since, is that clinicians and researchers, they live in a black and white world. They like things that are absolutely 100% true, and unfortunately, patients, well, not unfortunately, but from the clinician's point of view, they find it hard to really grasp this quality of life thing, because it doesn't match up with how many inflamed joints and what your blood results might say. So they just ignore it, basically. The patients, as I said, we don't ignore quality of life because it's the most important thing that we have. So this generated more of a discussion at the conference, and in the end, we basically decided to agree to disagree. Both sides of the camp had valid points as to why they were prioritising one score over the other. But in the end, we decided that our point of view was valid. And we really needed to have both points of view involved in this conversation. Otherwise, we weren't going to have the whole story. And it really validated the point to the organisers of the OMERAC conferences. From now on, we had to have consumers involved in this conversation, because we won't have the full story or the whole picture if we don't. It was a fantastic exercise for me to have as my first introduction to this conference, because it really showed me that even though I was nervous when I turned up, my point of view is valid, and my experiences mean something, and they're going to be able to change the way we do things going forward, particularly if we're lucky enough to be involved in organisations like OMERAC.
And if I could get you just to wrap up in a couple of minutes, just so we have plenty of time for discussion, that'd be terrific.
Absolutely.
Sorry to interrupt you.
No, that's all right. I was a radio announcer for a little while, so I could talk until this battery runs out of this laptop, but I won't do that today. So just to finish up, there was a little bit of a side conversation which happened when we were looking at these core sets, which were, the scores that we were using. So there was about 150 or so at the time that were being used to investigate inflammatory arthritis. And some of them we didn't even understand. But one of the clever consumers who was at this conference realised that there was one that was missing. We weren't measuring something that was really important to us, and we dealt with nearly every day. That was fatigue. There was no measurement in any research trial into rheumatoid arthritis that looked at fatigue. And it's a massive part of our lives. So we challenged the researchers to go away and investigate how they could start measuring fatigue. And it took a little while, about 8 years to be precise, but they came back to an OMERAC conference a little while later, and they had a validated tool which is now being used across the world to investigate fatigue. That would never have happened unless the consumers were shown all of the things that we use to actually measure or to investigate arthritis. And as I said, it's changing the way things are done. So in conclusion, all of that experience has led me to being able to support researchers and consumers to work together from something that I'm very passionate about. And the reason I love this work so much is because it actually gives all of us, whether you're a consumer or a researcher, it gives us an opportunity to make this world a better place. Generally, researchers get into the game because they want to make a difference and they want the world to be a better place, but it's a hard job being a researcher. I know from being in this industry for quite some time now, you get more kicks in the butt than you get pats on the back. So it's hard work. And for consumers as well, generally we come into this conversation with, not the nicest of experiences, but to be able to use that experience and team up with some clever people who are passionate to make a difference makes everything worthwhile. And as I said, it gives us all an opportunity to make the world a better place. And there's no greater opportunity in life than to be able to do that. So I wish you all the best of luck going forward with your work. And Angela, thank you very much for having me today.
Ben, that's an absolute pleasure. Thank you so much. And I'm going to hand over to Dash, who's going to facilitate some discussion, please. Some questions have come through on the chat or comments. Please keep feeding those through and we'll bring those into our discussion now. Thanks, Dash. Over to you.
Thanks so much. And thanks also, Ben, for highlighting the power of a holistic perspective and being able to draw all of those experiences together to be able to understand the overall holistic experience of something. We do have quite a few questions, and a few of you in speaking, Maddie, Anna and Ben, talked about the need for diversity and accessibility. And I was wondering what your thoughts were from a consumer perspective on ways that researchers and clinicians could enhance diversity and accessibility. I know it's hard, but any ideas that you may have? We might start with Maddie, then go to Anna and then to Ben.
Look, I think you really have to be on the ground where people are. In their communities. I think you have to have diverse people on your research team as well. And I think you need to have endorsement from the most senior people, endorsement and true engagement from the most senior people on your project, in making that effort as well. I'll just keep that comment brief. I think it's about being where the community is.
Yeah, thanks, Maddie. Anna.
Thank you. I think with groups that I'm with, say at ACBD and WeHi, the pool of consumers is already, of a good size and hopefully diversity. That obviously some research projects, it's more relevant to have people of either an age group or cultural or, with MPNs, as I brushed on before, that, they're almost unheard of in particular races. So it would be irrelevant maybe to have particular people involved. But I live regionally and not many people know what a consumer is. I kind of brought it with me when I moved here. And the reality is that researchers are in the capital cities predominantly. So, I think, and that's not going to change, but the researchers perhaps would think, I don't need people from my own capital city, because that brings, if you're fairly like-minded or similar background experiences, you're going to get fairly similar feedback in some ways. So depending obviously what the research is about. So I think, diversity includes age and culture and so many things, but also geography. Yeah. And to the sense that living regionally, and I'm very fortunate here with a phenomenal regional hospital, Sunshine Coast University Hospital, that we are well serviced, but obviously the more remote you go, the less opportunity you have that. And engaging consumers who, for instance, their experience in Far North Queensland, having to travel great distances on their own or with only one family member with a child to get to Brisbane or somewhere for treatment, that kind of thing isn't often thought about. And the treatments are there, they're wonderful, but where are they? So that kind of thing, I think it's an understanding or an acknowledgement on the research side and the consumer team as well to be ready to mix up the groups and bring in different people.
Thank you. Great advice in there, Anna. Ben, anything to add?
Yeah, I think that sometimes it's difficult for researchers who don't have an understanding of different cultures to be able to go and collect data from these people. You know, there's different ways of being able to collect particularly qualitative data that sometimes it's actually easier to ask your consumers to go out and collect data from you know, different societies and different cultural groups themselves, because of a level of trust and understanding that comes from being part of that community. I think that sometimes we need to spend a little bit of extra time training up our consumers to be able to help us to get some really rich data from the communities where they live, you know, utilising the lived experiences that they have to build relationships. And I think that it does take a little bit more time and effort, but it really does enrich the data that we collect and gives us more opportunities to actually make a difference with our research projects as well. So it's about developing relationships, giving people some skills to be able to go out there and feel like they're actually involved in the research project, and then allowing all that really rich data to come in and then allow the consumers as well to help you to analyse that data too. It really makes some great projects. That over here in WA.
Thanks so much, Ben. That's an excellent point. And we do know from the NHMRC Consumer and Community Involvement Statement that having consumer-led research, but training up consumers to actually be able to do some of that data collection and analysis can be incredibly important and powerful. So thanks for bringing that perspective. Maddie, I'm going to throw a question to you, which is about quality of life measures and how helpful they are, and you know, what the thoughts are around using that in research. So maybe drawing on your experience of having a look at some of those measures.
Look, I'm probably a bit tool agnostic, and it's been a while since I've been in the space, so I don't necessarily have a perspective on the Euroqual, which I think Catherine was asking about. I suppose I'd encourage you to really look closely at whatever quality of life measure you want to use. Take a consumer focused lens and evaluate the tool in terms of the language that it's using. So, you know, is it contemporary with consumer focused language? And basically, I know, if at least from diabetes perspective and dementia as well, that there are great language guides out there to help you look at, you know, whether your tool is fit for purpose. And I think sometimes language in quality of life surveys can be a bit problematic. You know, we're not suffering from anything. You know, I'm a person living with type 1 diabetes. I'm not a diabetic. You know, some people don't mind that, but I think it's worth being aware of that with the audiences that you're working with. I also would say, I think it's nice to be asked about the things that you can do as well as the things that you can't do or that are problematic in your life. So absolutely, yes, I mean, we're looking for deficits with a qual, but also I think it's important to be able to tell the other side of the story, which is all of the other things that are not impacted by whatever health condition you're looking into.
Great, thank you, Maddie. And Anna and Ben, wondering if you could share, how do people become consumers? Like, how do you sign up to be a consumer for research or healthcare improvement?
Shall I go first?
Go for it, Anna.
Okay. Well, in my case, I guess I just found out who the lead researcher was on the PV research and called her and went in to see her. So I guess it's a matter of stepping forward in one way or the other. A lot of people have been referred by other people who are already a consumer. And organisations such as WeHi and ACBD, when they're actively seeking more consumers ahead of, say, grant application season, which has just been put to bed. 14 documents later, I think, or 15, I lost track. But, you know, that they will ask consumers to consider other people who are carers and patients themselves. But I know particularly, you know, Centre for Blood Diseases at the Alfred in Melbourne are actively seeking right now, and they have a website and all that with that, which I can attach the link. WeHi as well recently, the buddy program, consumer buddy program, we're actively recruiting very recently. So often it's through somebody you know, or another experience that, for instance, the Cancer Council in Victoria after cancer treatment, or you may have volunteered at an event or something, you might get asked to come in for, say, a focus group. In the good old days, were done in person. And one of the things I went for was quality of life, another one on cost, private versus public, you know, all those kind of things that are crucial metrics for research and policy. So there's different ways, but I would start with the organizations that support a particular illness or condition, and the organizations themselves.
Yeah, thanks, Anna. And also just to say that Monash Partners is also looking to recruit more consumers. So if you are interested, get in contact with us. Ben, I'm actually going to change the question for you because I'm conscious of time. And John Carey has put in a very great question that I want to answer. Consumer perspectives on evaluating or showing the benefit of consumer engagement process. What should we be measuring? How do we capture the experience of consumer engagement? What questions should we be asking?
That's the million-dollar question at the moment. It's actually a piece of work that the Australian Health Research Alliance is undertaking as we speak, and so Monash Partners and MAC and WA Health Translation Network and others are all working on the development of such a tool that we would like to be able to use more readily to demonstrate the impact of consumer involvement within research. It's something that really it's been done a little bit overseas, so Canada and the UK are probably a little bit more advanced than we are, but it's not. We've had a look at a few existing tools, but we don't feel that they match in exactly with what we require here in Australia. So watch this space. I'm sure that Monash Partners will be having potentially a session like this on this very topic before too long. But I think it's something that we can all contribute to. So whatever you're doing within consumer and community involvement, do your best to look at what difference it's made to your project and any of the impacts that have enabled you to come up with the outcomes that you come up with. Just have a look at how what difference the consumers made to the project going forward. And I think if we can all compare notes before too long, we'll be able to come up with a really good tool that could be used across the country and help such organisations as the NHMRC to be able to demonstrate the difference that this work actually makes. We know from doing it ourselves the difference, but it's nice, as we all know, to have the evidence. So yeah, as I said, watch this space. We'll have something soon.
Fantastic. Thanks, Ben. Maddie.
Can I just quickly add to Ben's points? I think I would encourage researchers to also think, like, yes, there's ways we can use tools and, you know, our qualitative and quantitative research methods to demonstrate benefit. But I think we can also sometimes just really simply demonstrate it through the power of human storytelling. And I would encourage researchers to think about what are some strategic ways that you can tell the stories about your project. You know, it's really easy to make videos now, and I think that's a great way that you can share the impact of your work in a way that is very human and person-centered and emotion connected, and not just, I suppose, at the kind of management and policy decision-making level, but if you're looking to get access to communities, for them to be able to see their own people speaking to them in their language and experience. I think, you know, let's look beyond, you know, academia and publications is one really important area, but there are also other ways. I get that it's not going to help you get your metrics, but I think there's still value in the activity anyway.
Maybe we need to change the metrics, but thank you so much to all of our panelists. Conscious of time, it has been a fabulous experience listening to your stories, your experiences, what has worked well, what has maybe been space for improvement. I hope this has been a helpful seminar for all of you guys online. As we said, we've recorded it. We will be sending out notes and the link to the recording. Angela, was there anything else you would like to add?
No, thank you, Dash. Thanks to you and Victoria and the Monash Partners team, and a heartfelt thanks to our speakers today. It's been an absolute pleasure hearing your stories. Thank you for your generosity, and thank you everyone for joining us, and we look forward to seeing you. We'll take a break in July and we'll see you in August. Thank you so much, everyone.
Thank you.
And stay well, everybody.
Absolutely.